All right, then we're going to jump into some ultrasound guidance to regenerative injections. And like I said, these will be presented very much like cases that I've had. All right, so what are the benefits of ultrasound guidance? So one, immediate diagnosis and treatment. I'll talk about one patient where this was a little disappointing about where she's at with her care because of delayed diagnosis. Two, decreased pain and improved rehab. Opening up physician coach has made this probably one of the major sources of my diagnostics injections because I can treat their pain and then directly link them to either the PT that was referred the patient or our own rehab specialist that we have. Okay, and then expedited return to activity. Okay, so treatment options, corticosteroid injections, tenotomies. Does anyone know what that term means? Okay, so PRP kind of showed up as initially autologous blood injections where we put the whole blood back in. With that procedure, there should be what's called a tenotomy. So you go into the tendon, you guys will see this, you poke into the tendon and what you're doing is breaking up that tissue that has healed the wrong way to allow for better healing. And so there's now research coming out where do we even need the PRP or is the tenotomy what's actually fixing the problem? So sometimes that's all I do. Third, PRP injections, prolotherapy, which I use a lot less now that I have access to PRP, but there are some places that, like the plantar fascia for some reason, responds really well to prolotherapy versus PRP, and then nerve hydrodissections. All right, so first case report is going to be a little bit about a confusing presentation that ended up. It was two pathologies basically stacked on each other, okay? So this is the knee here. We're looking in short axis. Here's the joint, okay? Patellar tendon, and this is a nice fat tear, okay? So when I saw this patient, that's what I focused on. All right, so this is called PDI. I can't think of the acronym right now, but basically it's looking for low flow or hyperemia. We can actually see hyperemia on ultrasound. So what's happening is this is a freshly injured tendon, and this neovascularization has started because the tendon is trying to heal itself, okay? And so this can happen in multiple places in the knee. So one, I have the patient presented where that neovascularization was pretty much stuck in the tendon, and then the neovascularization where it was stuck in the fat pad, okay? Have you guys heard of fat pad impingement? Good. So again, this is, fat pad impingement is another one that I didn't realize was happening until not only did I diagnose it, but seeing the treatment effects. It's very, very easy to treat. All right, so, okay. And then this is the same patient, but now we're looking in the long axis, okay? So we're looking at the length of the tendon. And again, we can see that hyperemia is basically just only localized into the tendon versus when the neovascularization is coming up from the fat pad, okay? So this changes my treatment, and then initially with this patient, I was doing tenotomies, and they were not responding well. The pain continued to be there. And I didn't go to PRP because this patient wanted to keep training, and a tenotomy with a dry needle allows me to be a little bit safer in that they can continue training versus taking my actual injection needle, which is sharp, where I would be like, no, we need to be limited and do a progressive program. So it was not responding well, and it wasn't until I decided to then look at the fat pad that I realized that that was what we were missing. And first fat pad treatment, pain was gone after months and months of complaining, doing tenotomies, and not being able to train. Okay, and just to show you the difference between those treatments, and also the intricacy of getting the needle in the right spot. Is one, this is me separating underneath the tendon, pushing fluid into that area to separate the fat pad and the tendon. The intent there is I'm trying to break up that neovascularization so that those pain fibers are not still there, and then two, allow for better movement of that fat pad. And then with this other one, we have a tenotomy. So again, like I said, I'm going in there into that side of the tear, breaking up that scarred tissue so that the patient can then readdress rehab and hopefully lengthen those tendons back out the way they're supposed to be. And this is actually a dry needle. So it's have you guys done any dry needling yet? Tiny, tiny needles. They're super clear on ultrasound, so it's great. All right, so this was one of those access to care. So this patient had done, I think, 6 weeks of PT, had gone to ortho, who requested an MRI. MRI was declined from insurance, so she was sent back to PT for another 6 weeks, and was awaiting her next visit because the doctor was like, maybe now they'll let us order the MRI when she came to see me. And so she has a complete tear of the supraspinatus that has gone now untreated for almost 4 months because she can't get access to care. So in this image, we call it the like tire view. This is the rotator cuff interval. This tendon should be filling this entire spot. So it's a view of the supraspinatus and the infraspinatus as they lay over each other, and basically looks like someone just took a bite out of her supraspinatus, okay? And then same thing here in long view. We have those cortical changes like I told you about, indicating that there has been some type of damage to the tendon itself. Let's see if we can play that again. Oh, we can't. Anyway, so her presentation was more like this rim rent tear here. All right, so this is especially good if you have someone that for some reason their insurance is saying, no, we're not going to see you, or we're not going to approve this MRI. If they're willing to pay out of pocket, we can do a diagnostics and then hopefully get the answer for you guys and the answer for them to then know what rehab needs to be done. Okay, and then this is the plantar fascia. So I bring up this case because this is one that responds really, really well just to a tenotomy. So far, I think I've had 3 of these that I've treated, transitioned from prolotherapy to just trying a needle to see if that is enough. And all 3 across the board have never come back. So let's see if so we have the calcaneus there. This is a good normal plantar fascia. You can see it looks very much like a tendon insertion site. All right, and then this is a plantar fascia. I don't even know what to call it because we're supposed to not call it an itis anymore, right? Anyways, it's very, very thickened, very, very dark, and again, responded really well to just a tenotomy in that area. Okay, and then this is me coming in with a needle with the ultrasound guidance. Of note, this is there's a couple places now, I'll show you guys a video image of this, where when this is bad enough, I've actually had my 25 gauge needle hit that plantar fasciitis and just ride across. It didn't want to penetrate it. Okay, so there are times when you're dry needling, if you guys do take up that certification, where that needle might not be penetrating where you think it is. All right. And then these next 2 are going to be PRP results. So this is actually an adductor tendon tear. So when we look at the normal, we'll see the adductor longest tendon come in, has a nice big insertion site. Okay, we see a little bit of the muscle, and then the other adductors there below. When we look at this patient, we can see that there's a lot of cortical changes here. This tendon, we've lost the fibrillar architecture of it, and we even see some calcifications in that area. All right, that's the muscle there, okay? So this patient had about 3 different sessions of PRP. She was wanting to try PRP and not wanting to try a tenotomy first, so we went with that. And this is post results. She came back to see me just to get some dry needling done to loosen up her hip, but I wanted to see how the adductor looked. She had been pain-free then for a couple months, is actually doing our functional fitness classes. And you can see that that tendon fiber is now healed. All the way into the insertion.
Can I just ask a question here? Like your rehab after PRP versus tenotomy, are they pretty similar? Whereas like the whole point is to like get out of chronic inflammation and like restart the inflammatory cycle, so you need kind of strict rest for 2 weeks and then slowly build up from there. Is it working similarly with both procedures?
My rehab is the same. I am a lot more aggressive than my rehab. I don't recommend a lot of rest. I actually try to do isometrics right off the bat. And as soon as they can tolerate it, toleration, I mean I don't want sharp pain. Achy pain is okay because that's actually expected. Then they can start going from isometrics to eccentrics with PT, with guidance. But yeah, I don't have a fast and hard rule for you must wait this long. I say as soon as you can tolerate isometrics, start them. Mm-hmm. Yeah. All right, and then this is one case where I just did a tenotomy on a lateral epicondylitis. So radial head, lateral epicondyle, UCL, and then here's a small tear that he had right in the middle of it. Again, doing a tenotomy right into that section to make sure that's where I make sure the tendon does its healing. Okay, and then post-treatment, we did, I think, about 3 tenotomies, and we can start to see that linear fiber start to come back and fill in that space. At this point, he was pain-free, so we stopped doing treatment. Okay, and then this is the one where I've seen a couple times now my needle bend. All right, so this is that hamstring tendinopathy. You can see my needle is actually bending up the soft tissue, and it's not penetrating into the tendon. So for this patient, I actually had to switch to a spinal needle just to do the tenotomy because he didn't want to start with the PRP. But this happens, it's happened multiple times to me, so just being aware that when you are needling and you maybe, it's a different feeling with your needle when you can feel that it's not penetrating like it's supposed to, it's probably not, and you might need to switch to something else.